time, Professor Chitra Ramamurthy is starting her talk on 11 pearls and biometry. We all know biometry is the first step in achieving emetropia and planning the best outcome for the patient. So, Dr. Chitra Ramamurthy from Eye Foundation, Coimbatore. We all know him. I don't think we need to introduce him. Ma'am.
Very good afternoon to one and all of you, and very thanks, Dr. Ashok, for this wonderful opportunity to be part of your instruction course. So my due is to talk on the 11 pearls in biometry while planning for a premium IOL surgery. I have no financial disclosure, but we all know that to be at the helm of affairs, we need to be looking at our practices. Are we hitting target emetropia? Are we within plus minus 0.5 diopter of emetropia? And that is what is going to differentiate you from your neighbor's practice. So the Pearl 1 is to prioritize on optical biometer, which means that if we have access to the latest biometers, which the level of principles which they have, and the precision and the repeatability which is there in these machines, the swept source OCT or the PCI. Again, when it comes to accurate measurements, it is very important that you look at the fixation check, which that is what will define the accuracy of the axial length measurement. You look at the LED Myers and the topography, which is also shown on the side, which tells you whether there's an ocular surface disease which is underlying, which needs to be treated before you repeat your biometry. You need to look at the SNR values and the standard deviation values, because that also would tell you whether this map has not been well taken and needs to be repeated again. Today we have access to understand about the posterior cornea, and today the IOL Master 700 gives us information about the anterior cornea, and with the help of the swept source OCT and the B-scan, it gives us information on the posterior cornea, which is sort of interpolation of the values, and the formulas which can be incorporated with the Barrett TK, Barrett True K, TK and all. But what we also need to understand is there are certain formulas which assume, you take and make and assume a value for the posterior cornea, and if we use a TK value in that, there could be an overcorrection, so which has to be noted. Again, if you are using the immersion biometers, there are certain rule of thumb. The retinals, the spike should rise vertically, perpendicularly from the horizontal line, and there should be two spikes for the cornea, anterior posterior cornea, the lens and the retina, and also the scleral spikes should be visible. What is also important is that we ensure we do not compress on the cornea at all. The standard deviation should be less than 0.6. We should have at least 5 to 6 repeatable readings, and the lowest gain which is possible has to be taken, and thus you take your best measurements. Pearl number 2, we should always measure both eyes. Even if the other eye is a pseudophakic eye, there's a whole lot of information which you get when you look at the axial length, the ACD, the lens thickness, because the two eyes tend to mirror each other, and if there's an asymmetry, it might indicate to you that you need to repeat the measurements, or it could be an anisometropia, which you would conclude after taking number of repeat measurements. So that is why it's important to look at the measurements of the pseudophakic eye too. Now this is a 52-year-old patient with a PSC cataract. You see there's a difference in the axial length between the two eyes. Now if there's a difference in axial length of 0.3, that would create huge differences in the final value. A K value of more than 1 diopter between two eyes and an IOL part value of more than 1 diopter between two eyes should raise red flags in our minds, and we need to go back and recheck all the measurements. And this particular case, there's a difference in the axial length between the two eyes, and we found that one of it was an immersion value. So we need to repeat it on another modality if you have access to it, and we repeated it on an optical biometer. And then we found that earlier there was a difference of 3 diopters between the right and the left eye, but now it is 22 diopters in both the eyes, which makes it more significant and the better way. So it brings about more precision and tolerance in our measurements. There are errors in biometry, but today the optical biometers have surpassed themselves in the measurements of axial length. So the challenges now which remain is the captometry value and the ambiguities which come with it, and of course hence because of this error, you would be missing out on the effective lens position. So pearl number 3 is to optimize the ocular surface. What we have come to understand by the dry eye disease magnitude, that 60% of our phaco patients who are asymptomatic have in fact a dry eye disease, of which 63% of them have a tear breakup time of less than 5 seconds and 50% of them have central corneal staining. It means that we need to even measure the hyperosmolarity of the eyes, and it was more than 400, it's red flags. We need to look at the inflammatory markers in a dry eye disease. There is more than 40 nanograms, again it's a red flag. So it becomes important to look at the ocular surface and then check our measurements. Now in this particular case, in the right eye, the TK was 1.63 and the left eye 0.3. There's a huge difference between the two eyes, but when you look at the Myers, you realize it has a fishtail appearance. There's an artifact, one red on that topography. So it gives you a hint that probably it's a dry eye which you have not adequately treated it. So you need to treat the dry eye, maybe wait for a 1 or 6 weeks before you repeat your measurements. So then the important thing here is repeating measurements to get consistent values. In fact, it has been seen that more than 70% of the patients, it will be a cakewalk even if you have overlooked some of these measurements. But in 30% of the patients, you will find that the standard deviation, if it's more than 0.2, you wonder whether it's a dry eye disease. If it is a dry eye disease, treat for 6 weeks. But if it is not a dry eye disease, but the standard deviation is more than 0.2, then you wonder whether it was a refractive surgery eye or is it a pellucid. Then you need not to do only a topography, you may need to do a tomography. And if you realize there's astigmatic component, you need to put the patient on the toric calculator and use the latest generation formulas to get your exact measurements. So pearl number 5 is to use modern formulas. And why is it these modern formulas have an edge over the others is one. You look at this particular study, it tells us that the Hill RBF3 and the Barrett Universal 2 in 92% of their situations were within 0.5 diopter of target emmetropic outcome. And why is it so? Because the data which is analyzed with the Barrett to predict the effective lens position is not just axial length, corneal power, ACG, white to white, lens thickness, lens factor. And with this, it comes out with a number of formulas, the universal 2TK, the toric TK, the 2TK, the 2TK toric, and the Barrett RX formula. The Barrett formula has one more advantage, like the intraocular lens, based on the power of the lens, it could be a biconvex lens, a plano-convex, or a meniscus lens. And the principal plane of these lenses could be different. So in the Barrett, it also measures the principal plane of these lenses with different geometry and brings in that level of exactitude in our measurements. So largely many of us do use the Barrett toric formulas for, for astigmatic measurements. And what we do in our setup is even before the patient's tear film is disturbed to measure the applanation, we first put them, if they say they're interested in cataract surgery, and we first put them on the toric calculator, so that we get to know whether the patient has astigmatism or whether we need to counsel for a astigmatic correction. So then talking about astigmatism, we need to understand whether the patient had against the rule or with the rule when we are advising a toric IOL. The posterior cornea is steeper in 90% of the cases, which creates a minus lens along the horizontal meridian. So keeping this in mind, this patient in the right eye had an against the rule astigmatism. The standard K value is 0.5, whereas the total K value is 0.8. So then, when you put them on the toric calculator, it says that you need a T3 toric. In other words, if the patient has against rule in both back surface and front surface, the amount of astigmatism is going to be more and it would advise a toric. Again, parallelly, if you look at this eye, the left eye, it has a with the rule astigmatism of the standard K is 1.23. You think whether you need a toric IOL there, but the total K is 0.95. Because the posterior cornea is against the rule and the anterior cornea is with the rule, the total corneal astigmatism becomes less, and it says that you need only a non-toric lens. So how low would you go? We would go till the toric calculator tells us whether you need a toric or a non-toric in this particular eye. But when it comes to a multifocal, even if the astigmatism is less than 0.75, if the toric calculator allows, it makes sense to use the toricity correction also, because leaving a residual astigmatism uncorrected is not good for a premium IOL. Pearl number 7, you need to know about your toric calculator, and it also gives us information of the SIA or centroid SIA. And we now know with the understanding of the centroid plot that if the incision is 2.2 or less, the centroid value is only 0.12, and if the incision is more than 2.4 to 2.8, the centroid value is 0.3. So that is the amount of astigmatism which is created by the incision, and looking at surgical induced astigmatism is no longer necessary. Pearl number 8, if there's a pterygium and a premium IOL, and the pterygium is covering the visual axis or interfering, giving us irregular miles in the keratometric values, it is better to remove it, wait for a period of 6 weeks to ensure that the keratometric value are more consistent, and then take these patients up for surgery. Pearl number 9 is the role of aberrometry. If the cornea, in this eye trace, you can see the cornea has no higher order aberrations. These are going to do very well with the premium IOLs. But in this lower column, you see there's all those red, blue and all are indications of higher order aberrations. And these could definitely affect the choice of a premium IOL. Again, you need to look at the angle alpha. And if the angle alpha, the visual axis, and all are in one optical center are close together, these patients would perform most beautifully on a premium IOL. An angle alpha of more than 0.5 may not be advised to do a premium IOL, but today, the modern lenses, the central optic zone is quite large. Some of the modern latest lenses have 1.1 and 1.2 or more, and in these, even if your angle alpha goes up to 0.8, you can advise a premium IOL for these patients. Pearl number 10, in atypical eyes, you need to use appropriate formula like a post-laser vision correction eye. Different studies have shown that the myopic LASIK and PRK seem to do better than the hyperopic LASIK and PRK, and the Barrett 2K TK seems to be doing extremely well. When you look at the Barrett 2K TK, it asks you whether it's a myopic LASIK, a hyperopic LASIK, a radial keratotomy or a keratoconus, whether you are feeding in the measured posterior corneal astigmatism or the predicted posterior corneal astigmatism by the nomograms of the other formula. It also asks you to feed in which was the biometer you have used, and based on this it gives us the information. And what we do see is that the Barrett formula with the Barrett 2K TK is in 70% of the cases is within plus minus 0.5 diopters as against the different formula. Pearl number 11, you need to perform routine audits, analyze 100 cases. What is your target emmetropia? What is it which is happening in your hands, in the surgical hands, your precision? But having said it all, having told you about the accuracy of biometers and the kind of understanding which all of us in this audience have, what we also know that the effective lens position actually shifts post-operatively unpredictably. In other words, in this study by Hershen et al., in 17.6% of the eyes, the anterior chamber depth has shifted by more than 1 millimeter from 1 hour to 2 months. So imagine, we say we are able to nail the effective lens position on the operating table, but it may change as the patient heals. So probably we are yet to wait for a breakthrough technology, maybe the light adjustable lens or something more magical, wherein we could post-operatively adjust the IOL power and continue to stay with pride on a podium or to your patient that yes, you hit target emmetropia at all points. Thank you very much.
Thank you very much, ma'am.